Good evening and welcome to our first Digital Innovation in Women's Health Symposium. This is a new series that the Digital Health and Informatics Network at the University of Sydney is holding in collaboration with the Royal Australian and New Zealand College of Obstetricians and Gynaecologists, looking at the convergence between women's health and digital health across the lifespan. And tonight we're focusing on adolescence. My name is Victoria Peasley and I am the RANZCOG Member Engagement Lead for the ACT. Before we begin, I would like to start with an acknowledgement of country. We acknowledge and pay respect to the traditional custodians of the lands, waters and communities across Australia on which our members live and work, and to the elders past, present and future. I would now like to address some basic housekeeping. Please keep in mind all attendees are muted upon entry to the webinar. Be advised that this webinar is being recorded and will be posted on the DHIN site and RANZCOG's Climate e-learning site following the webinar. Should you encounter any technical issues, video or audio, please leave the meeting and try reconnecting. During the Q&A sessions, press the Q&A button, address your question, starting with the name of who you would like to address your question to, and ask your question. I would now like to introduce our chair for this evening, Dr. Sarah Woodbury. Sarah is an accomplished obstetrician, the only female obstetrician on the Northern Beaches. She has a special interest in risk management and preventative practices. Welcome, Sarah.
Thank you very much, Victoria, and welcome all listeners and joiners in. So welcome to a new event series that is looking at the convergence between women's health and digital health across the lifespan. Basically, each webinar will explore a distinct time in women's life, starting with adolescence, which we'll be covering tonight. The panel will discuss how they are using technology-enabled solutions in adolescent gynecology, mental health, supporting reproductive health of people with intellectual disabilities, and nutrition and messaging through social media. The panel will also share how they use digital health in their research and practice and discuss what advances have been made. Our speakers share how digital health is disrupting traditional healthcare and look at how far there is still left to go. A question and answer session will follow the speaker presentations. So after each speaker, there'll be time for 1 or 2 questions. Then there'll be a longer Q&A session once the speakers have had their say. So the Digital Innovation in Women's Health series is free and open to the general public. This event is a collaboration between the Digital Health and Informatics Network, DHIN, and the Royal Australian and New Zealand College of Obstetricians and Gynaecologists, or RANZCOG. Initially, I'd like to introduce our first speaker. Associate Professor Rebecca Deans is a paediatric and adolescent gynaecologist and a fertility specialist. After completing her specialist training, Dr. Deans undertook a fellowship post at the Royal Hospital for Women from 2007 to 2009, and subsequently went to University College London Hospital 2009 to 2011 to further pursue her training in paediatric and adolescent gynecology under Professor Sarah Crichton, and she still has a collaborative role in research at UCLH. She completed the certificate in reproductive endocrinology and infertility in 2011. Rebecca is an early career researcher and is currently a part-time clinical lecturer at University of New South Wales, with an appointment at the Royal Hospital for Women, New South Wales, and Sydney Children's Hospital. Okay, thank you, Rebecca.
Thanks very much for having me. And please let me know if you can't see my slides for whatever reason. So today I'm going to be speaking about technology and medical training, and particularly in the way that I'm involved in this, which is in, as you mentioned in my bio, teaching medical students and also pre-vocational and vocational ONGs. So the challenges that we have really for digital technologies, I think, is really the way that we link in with patients. And when you think specifically about the patient group we're discussing tonight, these are adolescents, and that's already quite a tricky group to get your head around at the best of times, even in a face-to-face type clinical setting. The challenges are in using digital technologies as part of education within universities, and also as we use it for our RANZCOG trainees, and utilising that to our best of our ability. And I think that there's plenty of opportunities, and I think that this has really been amplified really, and we've all become very used to doing Zoom meetings as a result, obviously, of telehealthing and COVID-19. But I think that, you know, one of the good things to come out of this is that we're much more used to meeting in this sort of format, and we can utilise a technology that's been developed as a result of our restrictions to improve healthcare for young women. So just a brief background, because I get to speak first about adolescent gynaecology and what adolescence is and how it's different. Obviously, there's plenty of physical and psychological changes that occur, and therefore, as a medical practitioner or any sort of treating specialist or clinician, you need to really alter your history and examination to reflect those changes that are occurring in that person's life. And it's often a time when gynecological disorders are first recognised, and it's also a time when sexual health starts to become an issue, and the adjunct things to that, so STI issues and screening and contraception. And just a brief summary for those of you that aren't particularly medical, that this occurs any time really between, it commences around the age of 10 to 11, and that's often with breast development, followed by pubic hair development, and then finally menstruation, which is quite a late phase of puberty, actually. And the psychological changes are probably just as important. So there's the developing sexuality and independence from one's parents. There's more seeking of peer acceptance and the person taking decisions over their own future. And then there's also changes for the parents. So they need to devolve their decision-making, encourage independence where they can. And the age that this occurs within families is quite different. It may not be consistent within the same family, but it also differs depending on social and religious and cultural groups. And you need to take that into consideration when you're seeing young women and their families. And this is probably the person you'll see if you see a young female patient. Often you need to discuss things like puberty, menarche, their cycle and whether there's pain, and also obviously whether they've been sexually active, and that's quite embarrassing and often is met with not much joy from the individual. You also need to consider that this is a risky time, so there's increased rates of teenage pregnancy and a range of sexual practices, and you need to take this into consideration. And so how do we engage in the health and community and help in being the caregivers for this group of young women? So that's done traditionally at the bedside, and this might be in hospitals or it might be within medical practices. But then increasingly now we're using things like schools programs, and that's been quite successful, particularly in, say, Adelaide, where they've had a school program for pelvic pain and capturing the number of young women who suffer with pelvic pain, and then the ongoing issues with that, like missing school every month. We need to engage really in social media platforms and engaging the community. And this can be quite important for education and information. And I think organisations like RANZCOG, or what we're joining today, really plays a pivotal role in trying to give the community really good quality education. Another great way to link in with the community, I think, is linking in with support groups, especially for rarer conditions, and they're the conditions I tend to get involved with, but also some of the common conditions that are rarely discussed. So endometriosis, for instance, pelvic pain has become much more of a buzzword and something that we discuss more frequently. And I think that's been that real linking in with the community that we can then now, as health professionals, lobby governments for more funding for these conditions. The education media platforms that we can use are things like webinars. Podcasts are fantastic, and we know that young people are more often reaching for podcasts to gain information, and online Q&A sessions as well. And then how do we take it to the other side? So how do we educate our medical students better so that they can better engage with the community? So the key issues that I really thought through are that for those of you who are doctors and involved in training for medical students, we're seeing a real change. Patients are much less tolerant of medical students in clinics. It's no longer acceptable to practice on patients as we once did. It was just the way that we learnt as junior doctors. And therefore, there needs to be an adjustment in medical education to try and accommodate for this, because the students are having less and less exposure to how we manage young women, in fact, any women within obstetrics and gynaecology. The other factors that play a role are the shorter hospital stays that we see now, more things like laparoscopic surgery, which is sort of in and out much faster, so you don't get that continuation of care, and so patients are less happy about seeing medical students because they're sitting in hospital for 5 or 10 days at a time. And we also see that there are more students in the system. There are many more medical schools now than there once were, and therefore there are more students in the system trying to gain that same exposure with less face-to-face contact. So how do we adjust for that? So there are static things that we can do. So we can use static models for training of anatomy, for instance. Pelvic models are very good. We've also got pregnancy type models where it's not just the bony structures, but you can actually see the fetus inside. And then you've got interactive models where you can actually do things like simulate a delivery using a model such as this. Then we can use things like simulators, which are online. There can be 3D modelling using videos and a combination of true videos and animation to demonstrate the more complex things that we need to teach our medical students about anatomy and physiology and things that happen in, for instance, normal labour. And whether there is a place for virtual reality in this space. And I suspect that we might come up in this in the panel discussion, but I think that there certainly is a place for this for emulating those more sensitive things like a vaginal examination, which is quite an intrusive thing to put a woman through. But if we can try and teach using things like virtual reality models, then I think that really is a room for improvement in the training of medical students in women's health. And then you need to think, for those of you in the audience who are involved with medical students, you're really teaching a tech-savvy group of individuals, and there's many online applications we can use, such as Geeky Medics, and these are applications that students can download to look at ways that they can do history and examinations, and they're really accessing this, and there's a real appetite at their end for trying to learn in this way. And I think as teachers, we need to start to utilise more and more of these online resources and e-learning. The other things that we are moving towards at the University of New South Wales are moving to more blended learning. Things like lectures which can be partly face-to-face or a combination of face-to-face and online. We also sometimes do tutorials using platforms like Blackboard Collaborate. So in that way you can attend a lecture online, and you can have individual tutorial groups, and the tutor can actually give a task and enter and exit a particular tutorial group. And I've used this particularly with COVID training of medical students, and it has been taken up quite easily with the students. And I think in fact, it was more the tutors that had more issues trying to get their head around this. Obviously, telehealth has enabled a lot more students to be present at patient encounters, and I'd be interested in either the Q&A or the panel discussion. Being a doctor going through COVID and teaching medical students, I found that often patients might say, no, I'm not happy for medical students to be present, or I'm not happy for more than one medical student to be present during my consultation. But I think when you have that online platform, you feel as though you're in the comfort of your own home and you're able to be a bit more open. And I found that patients have actually been quite happy about having multiple students log in to their consultations online, and they don't feel quite as embarrassed. And I'm sure there's a research project or a PhD in there somewhere, but it's just something I've noticed. Obviously, research is much more online and accessible. And then we've got the good things. So where students are gaining their information online and we have the issues with copying and pasting, you can also use things like anti-plagiarism tools such as Turnitin. And I think that these are all really fantastic new tools, and they're not all so new, but as we move more and more to e-learning and utilising the internet and other techniques of teaching our medical students, we can use these techniques too. Finally, you know, nothing really compensates entirely for face-to-face, and sometimes we use things like human models where they're paid actors for examinations which are sensitive rather than using the patients, and therefore that's a little bit more ethical in a way to teach the students without actually compromising the patients. And then our examinations now, we often use an OSCE type situation. This has been used for many years. But what we try and do in these stations is to mimic a clinical scenario, whereas in the past we had patients come in and we would examine each individual patient or take a history. We actually can utilise things like role playing or have a station where there is a computer and you can access information online. And it's really teaching the medical students to be able to access information in that way, or research a clinical question, and to be objective about the type of websites that they're searching and how to critically appraise the information that they're receiving from the internet. And then moving on to the RANZCOG trainees. So these are people who are going to be obstetricians and gynaecologists one day. So the same sort of issues exist. We now have more training. We have improvement in safer working hours. So whereas in the past the registrars would do 24-hour shifts and 100-hour weekends, we now can't do that with training, and that's for the safety of everyone. But the result of that has been is that there has been less face-to-face education for these trainees in obstetrics and gynaecology. And as a result of this, we've needed high levels of senior staff available to manage clinical scenarios where those scenarios were able to be managed by more junior registrars. We're finding that registrars are coming through and needing a lot more support. There are much less surgical procedures being performed in gynaecology, and this is a result of lots of different things. But a good example of this is the advent of the Mirena IUD. So in the past, in the 80s, I think 40% of women had a hysterectomy for heavy menstrual bleeding. Now it's just a tiny percentage of women have a hysterectomy because we have better medical treatments for that condition, and therefore there's, in a good way, it's better because the surgeries aren't being performed, but it actually leads to less training for our trainees. And this obviously puts pressure on the hospital systems, and unfortunately trainees, come out with less clinical skills. And so how do we train them in the same way, but without actually having the ability to give them 100 hysterectomies, which they may have done in the past during their obstetrics and gynecology training. And so therefore we've had to be a little bit more creative in the way that we train our RANZCOG trainees. So we can use things like online modules of, in obstetrics, there's a program called K2. So this teaches you about managing women in labour and reading a CTG, for instance, and there's e-learning modules where you go through credentialing in that way. We need to utilise surgical skills and acute care courses where you can simulate those sort of acute situations, and then people can run through them in the most real life fashion. And then following that we can also use simulations for advanced life support, so CPR, and this can be done in the adult population and even in neonatal resuscitation. So we try and do what we can to put those trainees in a position where they're not learning on the job, or they're not doing something for the first time when it's in an acute situation and they're stressed and perhaps not performing as well as they could be. So for training in hysteroscopy, so for those of you who aren't, and I know it's a mixed audience, but those of you who aren't obstetricians and gynaecologists, hysteroscopy is where we put a camera inside the uterus to look for any problems within the uterus, like a polyp or a fibroid, or to look for reasons why a woman might be bleeding, or whether she may have a precancer or a cancer. Traditionally, you just did many of these in your training. Now we can use simulators with a pelvic model, so a static model that you can see there, using the camera. And you can practice doing things like removing polyps and fibroids. And so therefore you can do more of these in preparation for actually doing them in the real life model. And we can also do this in laparoscopy. So this is the keyhole surgery of the abdomen, and you can utilise really quite technical structures like the image on the left, where it very much feels like a real life situation, but it doesn't have to be as high tech. And that's why I've got the picture on the right, where you can really use fairly basic instruments to gain some increase in those clinical skills that are so critical for training in surgical skills. And this can be performed just using a plastic box and trying to gain that, that tactile sensation of operating laparoscopically. And then virtual reality has definitely come into surgical space, where you can utilise that to improve your surgical skills as well. So you can have the much like a video game, you can wear the goggles and have that sensation as if you're in surgery. And I really do think that this is the future for our RANZCOG trainees, where we're going to have less and less exposure to real life patients, and you really need to rely on these sort of settings. And robotics, once again, is a changing field within gynecology, and I think the training, once again, can be outside of the patient. And indeed, when you do perform these surgeries on the patient, you are sitting away from the patient. So it's really moving in that direction. So I think that importantly, I'm not saying that we give up face-to-face, because I think it's fantastic when you can actually experience that firsthand. You can actually attend a clinic and sit in and see what the communication is between the doctor and the patient, and obviously operating and learning that skill. Doing it in real time is so important, but I think that we can blend the learning so we don't rely on all of that, that learning individually on the patient. We need to do more research in this space, and there's certainly a lot more research that is being invested in training in this way. And I think a combination of these techniques is crucial. And I think that we'll be able to train our RANZCOG fellows in the same way. So why can't we use these same things to receive CPD points? So, and I think that RANZCOG is moving in this direction. Webinars, online modules will be utilised for continuing medical education. Webcasts and podcasts, I think, are a fantastic way of keeping yourself educated, and it's a really excellent way for adult education, and interactive hubs as well, possibly using a VR set at home to keep your skills up, because part of our ongoing continuing credentialing of our skills requires a certain number of procedures to be performed every year. And if you can't access those procedures, or if you happen to be unwell, for instance, for 6 months as a RANZCOG fellow, you can perhaps compensate for that by keeping your skills up to date in an interactive hub. And I think this will be a really wonderful thing that RANZCOG will move towards in the future. So I think that unfortunately we need to move with the times, or fortunately or unfortunately, we need to move with the times. And I think that this is a great forum to discuss how we can do this and help our young adolescent patients.
Great, thank you, Rebecca. That was very informative. We may have time for the speediest of a quick question if anyone wants to do a quick Q&A on the Q&A bit. Otherwise, we'll leave things for the general Q&A a bit later. And you make some very good points there. Very good. Okay, it's time to introduce our second speaker, E-Lin Chang. She's a Senior Health Promotions Officer, Disability Family Planning New South Wales. E-Lin has over 7 years experience providing social and recreational support to adults with disability in a variety of roles. In her role at Family Planning New South Wales, E-Lin leads a team of health promotion officers and educators working towards improving the reproductive and sexual health of people with intellectual disability through education, advocacy, and the creation of accessible resources. She has been leading Family Planning New South Wales's new project, Planet Puberty. Okay, thank you, E-Lin.
Thank you, Sarah. Thank you for that lovely introduction. So as Sarah said, my name is E-Lin Chang. I'm from Family Planning New South Wales, here today to talk to you about our new project called Planet Puberty. So I'll just share it with you. Bear with me. Let's start this. So Planet Puberty is, so it's taking a slightly different tack from the previous presenter. So Planet Puberty is our new digital resource, as it suggests there, for parents and carers of children with intellectual disability and autism, focusing on puberty. So I'm going to talk a little bit about how we came about with the concept of Planet Puberty, what led us to create this digital resource, and background as part of that. Talk a bit about the approach we took in developing the resource and the different components. I'll play you a short video of the resource, showing the different aspects, and talk about what next and sort of where we see, I guess, a digital resource like this fitting in with broader support for parents and carers and children with intellectual disability and autism around that sort of a key stage of puberty. So just to start and following on from the organisers, so in the spirit of reconciliation, Family Planning New South Wales acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander people here today. So a bit of background. So Family Planning New South Wales has been supporting the reproductive and sexual health and rights of people with intellectual disability and autism for over 30 years. It's something that we're very passionate about and have a specific team that focus on this really important area. And we know it's an area that really doesn't get talked about enough and doesn't get a lot of attention. So what we do as part of our work, focusing specifically on our disability aspect, is so resource development. So we have an image there of some of the resources in our disability resource collection. So this Planet Puberty resource is one of the key resources that we have, but also includes other things like easy English, fact sheets, books, videos as part of our resource suite. We do training and education for parents, carers, teachers and support workers, and this actually connects to some of the work that we've been doing here at Planet Puberty, particularly in terms of our work with parents and carers, and really that focuses on a capacity building approach recognizing that a lot of the barriers that come, a lot of the barriers for people with intellectual disability and autism in accessing better reproductive and sexual health education, healthcare, their rights, is in relation to barriers from people around them. And so that capacity building being a really important part of our work. We also have a lot, do some advocacy around more systemic advocacy in terms of how we can promote the reproductive and sexual health and rights of people with intellectual disability. So, making submissions to the Royal Commission, for example, and recently into a Senate inquiry into autism as well. And finally, we do some therapeutic work, and we have a psychologist as part of our NDIS service, providing therapeutic relationship and sexuality support to people as part of their NDIS plan. So how we got to, this Planet Puberty project is, so we, for many years now, have been doing a lot of work with parents and carers. And what we've found and what research has shown is that parents and carers are often under-resourced and lack confidence and awareness that their children require sexuality education and support as their peers without disability. Often making a lot of focus, particularly in sort of that childhood period, on the various needs, schooling, and all those other things that come along with that. And then suddenly they're hitting puberty, and things are changing, behaviors may be starting, and they don't know what to do. And that's often a point where they get in contact with us. It's often when we see parents coming to the workshops we run in conjunction with schools. And there's a lot of uncertainty as to how to approach supporting their child in a positive way that also helps to keep their child safe. So in our own research, parents kept telling us that they needed more information that focused on concrete strategies that they could use with their child, and that they needed that information to be accessible at a time when they needed it. Their parents may be coming to our workshops because we're at their school, or if we had funding to go to a regional location, we might go to far north coast once every couple of years. And parents are telling us that that they had a lot of anxiety about what if they missed out that workshop and we couldn't come for another 2 years. What if they needed advice from us after they attended because something changed. And so that gave us the idea that moving with where we're seeing a lot of health information transitioning to looking at how we can make a digital resource that helps to provide some of that information in an accessible way where parents can access practical strategies and other resources when they need it most. So with funding from the Department of Social Services in 2019, we sought to develop this new digital resource for parents and carers on how to support their child with intellectual disability and autism, through puberty. So the resource was aimed to be informed by the things that adults with intellectual disability and autism today would have liked to know when they were younger. So really looking at taking experiences of people who've been through it already and using that to provide advice for parents today on how they can better support their child. And really taking a holistic view as to what we're talking about when we're talking about puberty. That we're not really, like Rebecca alluded to, we're not just talking about physical changes, but looking at social and emotional changes as well. So that we really are supporting a parent to help their child through all the things that will come along during that key transition period. So how do we do it? So we set up a number of different sort of mechanisms to engage with people who would be using the resource and whose experience we wanted to inform the resource. So we worked with nearly 100 people across the country, including adults with intellectual disability and autism who formed part of our co-design team, and had a key role in leading some of the more the principles behind the resource and some of the key messaging behind it. We also work with parents and carers and key stakeholders. And as a national resource, doing that, engaging with people all over the country. So their involvement included providing advice for the overall project, and that, that being as part of the different sort of groups that we had, so the co-design group, the parent and carer group, and the key stakeholder advisory group, all were part of initial interviews to understand needs. So we were doing this at the peak of the COVID time, so lots of webinars and phone chats. They're talking to people about what they would have liked to know, what type of resources would have been useful, what type of information do they want, if there is a digital resource, what kind of resource would they like, and they're keeping quite an open mind as to how we were creating and what we were creating. They're also part of developing and reviewing our page content. So I'll show you a little bit later, but we end up with a website with, we've got about 70 different subtopics across 5 sort of different broad topic areas, all reviewed by at least one parent and at least one person with intellectual disability and autism. So making sure that's really relevant and practical in what we were writing and developing. We have some videos on the website as well. So we have interviews with parents and carers and people with intellectual disability and autism talking about their experience. So interviews for videos and also for a podcast. The podcast was actually something which we hadn't planned initially, but was something that in the initial interviews we were doing, people were really saying that the parents were really saying that's how they access information. So they've dropped the kids off at school and they pop in a podcast and they listen then, or in bed at night after the kids are in bed, listening to their podcast and getting the information at that point. We also had people co-hosting educational videos, and that was a really important part for us. That it's not us as professionals telling people how they can teach someone something. It's really we had co-hosting with an adult with intellectual disability and autism, showing parents today how they can do something, how they can teach their child as well. We also had the people testing the website prototype to make sure that it really usable, accessible, and the whole concept of the Planet Puberty idea, working with our design agency, GHJ Sydney, with our co-design team to make sure it's something that would be interesting and captures an audience's attention. So introducing Planet Puberty. So it's a website with information, strategies, videos, downloadable worksheets, and a whole range of suggested resources on the following topics. So as I said, taking a really holistic view, so body, relationships, identity, feeling good, and keeping safe. So really looking at a broad spectrum there. We've got a podcast series, which just launched yesterday, actually, so you can access that wherever you get your podcasts. We have a webinar series, so over the next 6 months, we'll have fortnightly webinars on a range of different topics. And that just started last week, so we'll be on next week, for example, and a hard copy booklet as well. And that's something which, in the interviews we're having with parents, that they were very firm in wanting that digital resources are good, and that that they can be accessed when they want it. But some people, if they're not as good with their computer skills aren't as good, or the internet isn't great, that hard copy booklet being something which, a tangible thing which they can refer to at the same time as accessing other digital resources. And that's something which our stakeholder group, for example, were really interested in having as well, something which they can give out to their client base, to direct them to look at the broader resource online when they needed. So I'm going to show you a quick video, and this gives you a little bit of a summary of what we've been up to.
Hi, I'm Jess.
And I'm Erin.
We're here to talk about periods.
Yeah. So Liam, do you want to show me, what do you think is a good example of a private space?
Like this single bedroom. That's a private place.
Well, I knew that it was a period. I knew that it was the lining of the uterus coming off. Because, well, when I was little, my mum was very open with that stuff.
Tampon is sort of a little version of pad, but you put it in the vagina, and you have to make sure the string is outside.
A way of helping equip my daughter with some of the skills is to give her a voice to say no.
So to show you how you can teach your children about private body parts, we're going to do a brainstorm and we're going to use these dolls and some strategies.
Explain it to them, and if they get overwhelmed or they take their pads or their tampons out, don't get mad at them, because that's just going to make them anxious and instill the fear that this is something wrong.
Katie, what do you think we should do with those examples? I'm asking the questions now.
Oh, okay.
Okay. Oh, there we go. So, what next? So we've just launched Planet Puberty a couple of weeks ago, so it's really still very much in the promotional stage, really getting the word out there. Initial feedback so far has been really, really positive. And you know, we're getting a lot of engagement in our webinars and also with our social media promotional advertising as well. So in terms of what next, so we're going to add more. We're going to add easy read content to the website, and that's, you know, we're really sort of, I guess, something reaffirming that, you know, importance of accessibility in creating resources like these. We're going to continue to add educational and instructional videos. We've got more in the pipeline. Continuing with webinar and podcast series, as I said, both just launched, and continued promotion through networking and social media. And this is an interesting one. So we do have, you know, as a national resource, we're never going to be able to get everywhere to promote it. So social media being an important part of that, but also as well, I guess, is in terms of how we look at digital health, that, you know, while it's a digital resource and we're using digital means to promote it, there still is that really important aspect of that person-to-person connection. And that's a really important part of why we've, you know, developed our key stakeholder advisory group, and using their connections to help pass on that information from a trusted service that they're accessing. And similarly, part of that being dissemination of hard copy resources, and that being something which through that collection of those different avenues being an important way to help, you know, that a bit of a traditional, a bit of sort of digital aspects to really help to promote better support for children with intellectual disability and autism through puberty. And yes, that's the website there, planetpuberty.org.au. And yeah, do check it out. And if you'd like to promote it to any people you might think might be interested, that'd be really wonderful. Thank you.
Excellent. Thank you, E-Lin. That looks like a truly tremendous resource, and well done to you and the team on all your hard work.
Oh, thank you.
Sure,
it was a lot of fun.
Very useful. Yeah, it looks really good. Thank you. No one has popped up with a question quite yet. That's okay. We might roll on to well, not literally, move on to our third speaker, Dr. Natalie Lister. She is an NHMRC Early Career Fellow at University of Sydney Children's Hospital at Westmead Clinical School. She's an accredited practicing dietitian and has a PhD in nutritional science. Her research interests include investigating dietary interventions that will prevent and manage obesity, diabetes, and cardiovascular risk in children and adolescents. Natalie is particularly interested in individualised care and the role of eating behaviours, dietary components and diet quality in improving health. Recently, Natalie has been investigating the nutrition information available to adolescents via social media. Thank you, Natalie.
Thanks, Sarah, and thanks for having me to speak today. So I'm going to be talking a little bit of a different approach to the previous speakers and describe some of the project that we've been working on, looking at what information around dieting and diets is available to adolescents via social media. So our particular work is in adolescent obesity, and we know that adolescent obesity is increasing, and that adolescents will come to us reporting attempts to lose weight and using both healthy and unhealthy strategies. So we also know that many adolescents aren't actually engaging in professionally led obesity care or any health services, and particularly we've seen this during the COVID pandemic, that many adolescents are actually going online for their health information and also their nutrition information. So anyone who is familiar with an adolescent will also know that they are quite familiar with social media and frequently use social media. The statistics on how frequently and for how long are really quite mixed, and so we think it's quite frequent, up to 2 or more hours per day on social media, not just on their device or their screen, but actually accessing social media sites. And the most common or frequently used ones are YouTube and Instagram. And this data is a little bit old from Snapchat, but I suspect TikTok is up there, and some other of the more emerging social media platforms. So what we wanted to do was have a look to see what information was available to adolescents via social media around dieting and weight loss, and what they could actually view on these platforms. So we conducted a content analysis. So we created a new Instagram profile for a 16-year-old of no specified gender. And we really looking at the hashtags weight loss, hashtag intermittent fasting, hashtag keto, and hashtag low carb. Now, if you're not an Instagram user, the hashtag is a label that you can apply to an image when you upload it, and people can then search those images. And when you search the images, they're either presented as a top image, which is like the most frequently engaged images, or a most recent image. So we really focused on those ones that are highly engaged with, the images that are highly engaged. And we coded them according to a predetermined framework. So this was an emerging methodology that's been used in a few other hashtag related strategies or studies, but we also adapted some of the methods from qualitative research principles. So I'd like to thank Dr. Hiba Bailey, who was helping me with these, or has helped develop these methods and shared some of her slides with me for this evening. But really the codes that we were really focused on were food, individuals or people, and information. And within that, we looked at some different subcategories. So for the weight loss hashtag, we really defined the people by their sex, ethnicity, body type, and the pose that they're in for the image. For information-based images, we looked at whether there was a positive message or a negative image, or whether it was promoting a particular nutrition information or product. For the diet-based hashtags, we also classified food in a little bit more detail. So we were looking at whether they were according what category they might fit into according to the Australian Guide to Healthy Eating. So I'm actually not going to show you the images that you can see under these hashtags. There are some IP issues around sharing the content of the hashtag in a platform like this, but I do encourage you to have a look if you are an Instagram user to go and have a look at the hashtags, or if you're not an Instagram user, you can also view that through your web browser if you navigate to Instagram, and you can search these hashtags without being a user. So we collected data in August 2020 for hashtag weight loss, and there was at the time 67 million posts. And we coded 600 images, and they were really predominantly of people, so either individuals, groups of people, or before and after photos. And I'll go into a little bit more detail about that in a moment. But when we broke down the food into what we looked at for the Australian Guide to Healthy Eating recommendations, about 70% of that was core foods, and about 30% was what's defined in the Australian Guide to Healthy Eating as a discretionary food, which is really just what you would consider to be a junk food. So high in fat, sugar, salt. So when we looked in a bit more detail about the images that portrayed people, what you see is that the majority of images are of women, and they're predominantly white women. They're thin to average adiposity and quite muscular. And they're often posing in a fitness-related or a sexualized pose. And so this study was actually published earlier this year in the journal Childhood Obesity. So let me know if you'd like to hear more about or see that publication. But I'll move on quickly to just present the results of the what we see under the popular diet hashtags. So we looked at intermittent fasting, keto, and low carb, and you can see there are millions of posts per day. I mean, millions of posts at the time of data capture, which was in September last year for the first initial data capture. And they're predominantly of food, or then people, and then information. And so when we looked at the imaging, the information-based posts, really we saw quite a lot of negative messaging, shaming, guilt, and very little nutrition information were the main findings from the information posts. When we looked 6 months later at the same hashtags, there were a few million more posts in that 6 months, but not a huge change in the proportions of images that were food and people or information. So we then categorized further into subcategories for food profiling. And so these categories are based on the Australian Guide to Healthy Eating, but we also added a few based on what we had seen in the hashtags. So what you're looking at here is a list of the categories down the side, and along the top is the percentage that they are of the total images, so of the entire images. And what we see is that predominantly we have animal proteins and vegetables being represented for food. And 6 months later, again, we still see those predominant animal protein and vegetables, but we also see some more dairy images being posted under intermittent fasting. For keto, we see, again, this is a similar chart showing animal protein and vegetables are the predominant food images. And that remained true after 6 months later with the additional few million images. And finally, for low carb, again, we see animal protein and vegetables. But what was really interesting about this one was that we saw a lot of cakes. So a lot of cakes go into the low carb hashtag, and that's why desserts creeped up quite to almost the equivalent of vegetables. So almost as many dessert or cakes as what there is vegetables. Not quite as much the second time around, so more vegetables the second time around and not quite as many desserts. But because of that initial finding, what we decided to do was have a little bit more of a deeper look into the low carb hashtag. And we've had a student, Megan Curley, looking at this, and she's a nutrition and dietetics student from University of Sydney. And so she's currently doing this project and has very kindly shared some of the data with me to present to this evening. And so she looked at 195 images, of which of those had 69 had recipes attached to them. So that was either in the caption or through linking to a link in bio or within the slide carousel. So when we looked at the recipes, 50% of those actually were considered to be junk foods. And none of them were sources of fiber according to the international standards of what would be considered a source of fiber. So I'll just quickly go through this this chart here. So what Megan did was actually categorized the recipes based on the carbohydrate content. So she had very low carb, which is less than 10% of energy coming from carbohydrate, low carb, which is between 10 and 26% of energy, and then medium to high carb, and which is considered not to be a low carb recipe. And what she actually found was that 30% of images, 30% of the recipes that we had were not actually considered to be a low carb recipe, even though they were under the low carb hashtag. And this chart is actually showing the percentage of macronutrients within those foods or recipes. And so what we see is that as carbohydrate is going down, so closer to the very low carb, we see that fat is actually going up, and so too is saturated fat. And when we look at the recommendations for Australian Dietary Guideline macronutrient recommendations, we can see that all of the recipes were above the recommended saturated fat guidelines of 10%, and they continue to go up to nearly 30% for very low carbohydrate recipes. So, and another interesting finding that Megan has found is that a lot of alternate ingredients were included. So things like alternate flours, almond flour, rice flour, coconut flour, of which were not always low carb. So rice flour and oat flour are not considered to be low carb alternatives. So in summary, a high proportion of weight loss imaging on Instagram that is visible to adolescents, and I think it's important to remember that this is something that adolescents can see, is really focused on accentuating body features and of thin white women. And diet hashtags tend to promote animal-based foods with or without vegetables. But really there was a lack of any kind of useful nutrition or exercise information or behaviour change information on Instagram. And I will leave it there.
Thank you, Natalie. That's very fascinating, very interesting. Having teenage girls at home myself, very interesting. I do have a couple of questions. You have a couple of questions. Let's ask two at the moment. So first one is from Louise Bohr, and she asked, Natalie, how many posts do you need to analyse to get a sense of content for a given hashtag? And any work on the validity of the sampling and lessons for other researchers?
Yeah, thanks, Louise. I guess the response, so this is an emerging method. So previous studies have just sort of guessed that a couple of hundred images might be enough. But what we did was actually with Megan, the student that we're working with at the moment, actually looked at a saturation point, which is from qualitative research, where you basically continue to code the images until there are no more themes or images emerging. So what she found was it was only 195 images was what was needed to no longer see themes emerging, which is about 13 scrolls of a iPhone. So 13 thumb movements, and you've got the message from the low carb hashtag. So it might be different with other hashtags, and that's something for future research to have a look at.
Okay. One more quick question. Okay. We've got a question about how your participants were consented for this study.
So we didn't require ethics approval for freely available information that's in the public domain. So you don't need ethics approval because it's not actually conducting research on participants. It is information that is in the public domain, but we can't republish the information, which is why I'm not sharing any of the pictures with you tonight.
Okay, all right. I think that covers Dennis's first question there as well. We'll leave the other questions because we do have to get a little wriggle on. But Natalie, it looks like you're going to be asked a few more questions later too, if you can hang around, thanks.
Sure.
So our fourth speaker is, let me just grab his bio, Dr. Mitchell Dowling. He's a clinical psychologist working at Headspace Camperdown and a postdoctoral research fellow working with the Brain and Mind Centre's Youth Mental Health and Technology team. He has specialised in treating young people experiencing mental health problems, conducting clinical work in Headspace centres for the last 5 years. Mitchell's research experience has explored the development and implementation of technology-enabled solutions in mental health care. He's currently working on developing the education and training program for the BMC's highly personalised and measurement-based care model to manage youth mental health. Great, thank you, Mitchell.
Yeah, thank you very much for the kind introduction. So yes, I'd like to talk briefly today about how do we bring technology into standard mental health care with young people? And from my own practice, I've looked at a few different areas, but essentially there's the health information technology platforms that can be used. There's telehealth options, internet-based CBT programs, mental health apps, and biofeedback devices. All that I've been using in my own practice, as well as doing some research on. So I'll start with the trial of a health information technology platform. So I think in 2019, the Interworld platform was introduced to Headspace Camperdown that allows for online assessment, monitoring, and provides clients with access to a variety of apps that they can use based on the various different areas that they've shown they may need help with. So one of the things that the first things we noticed in terms of the benefits is the reduction in the duration of the face-to-face assessment. So in clinical practice, you might have the heads assessment, and then a clinical psychologist might go on to do a further assessment, and assessment can go on forever and ever and ever. One of the good things about the platform is that it helps narrow it down to, particularly if they're looking at anxiety, depression symptoms, or if they're a more complex case, and particularly handy in cases of, areas where you may not ask questions as readily, such as manic symptoms or psychosis symptoms. One of the other benefits was there's an earlier response to risk. So there's suicide-related questionnaires that allow you to actually call the client immediately if they're posing as having a higher risk of, risk is the wrong word, but yes, greater severity in terms of suicide symptoms. And then, of course, there's the support for treatment planning. So we know that some of the various areas that are particularly important for young people are not just mental health symptoms, but we're also looking at social and occupational functioning, drug and alcohol use, suicidal thoughts and behaviours, self-harm, and physical symptoms. And using this health information technology platform allows you to actually start providing interventions at each of those domains, which is very handy, and otherwise it's hard to remember. And finally, one of the benefits has been the session monitoring. So you can actually start to track progress session by session, or you can run through some of the more in-depth questionnaires at session 6 and 10 for your reports back to GPs. However, there are also barriers, and one of the first ones is there is an additional work demand when you start to use technology, and it requires a bit of extra effort particularly to convince the young people to complete the questionnaire more than once. Again, I think this has a lot to do with your own interest as a therapist in using the technology and the monitoring, and the young person will generally follow your lead, hopefully. But of course, if you leave it to their own devices, you often forget. So that is one of the barriers. The other one is the high expectation for technology. I know for myself, I'm always hoping that the technology will do X, Y, Z, because my expectations are based on, I don't know, Google and iTunes and everything else that just runs so seamlessly. But yes, we always have to temper our expectations. So the next, sorry, I'm just aware of time, so I'll run through these rapidly, which leads me to the rapid shift to telehealth. And the context of this was obviously COVID-19 traditionally Headspace Camperdown was pretty much entirely face-to-face. And in the space of about 1 week, we transitioned from a face-to-face service to a service that was running entirely via telehealth. And it's quite remarkable in just how smooth that transition was. I was working with a master's student supervising one of her projects, which was looking at some of our data through Headspace Camperdown. And some of the things that we were finding was, first of all, there was an increase in the attendance rates for young people. So they're actually attending more sessions. There were fewer missed sessions, which is fantastic. Part of that, I'm assuming, was because it's easier to access the telehealth sessions. The other part, I'm assuming, is that because they were trapped at home and there was nowhere else to go, so it was easy to track them down. I think those attendance rates have dropped a bit now that everyone isn't locked inside as much. The other benefit that we noticed was there were similar treatment outcomes. So based on the data from the previous year, there was no significant difference in treatment outcomes. And then lastly, there were similar levels of service satisfaction. So the acceptability of telehealth amongst our young people was quite high. And there were small groups of people that had a strong preference. And still I have clients that prefer just to have telehealth and some that just prefer face-to-face. But overall, people were quite happy either way. And my current load is roughly around 50-50 telehealth to face-to-face. However, the barriers that we were facing, well, I was facing in particular, technical difficulties, getting the internet to work. I'm pretty sure, my house, anytime there was a bit of rain, the internet would drop out, and I'd have to use my phone. So that was always a bit of a challenge. And other ones, if Zoom isn't working, for example. And then, of course, there's the risk management aspect, particularly if you do have a suicidal client. And then, of course, there's managing privacy issues. I've even had sessions now where people have been talking on the bus and just go, well, obviously you can't talk terribly openly when you're in a very public place. So, yes, so there are those issues to manage. The other area that started experimenting with COVID was introducing internet-based CBT into the practice. In particular, This Way Up, they made their services free for everyone during the pandemic or during the lockdown, and it's still currently free if you're prescribing your clients as a clinician. So it's an excellent service. And the benefits that I noticed in particular, because at some point the wait list for Headspace is about 3 months from contacting the service to actually seeing a psychologist face to face. And when one of the clients has actually completed something like an online CBT course prior to treatment, it's actually fantastic as a clinician to then talk to this young person. They have quite a good grounding in what you're going to be discussing in therapy. So it allows you to work on more the fine tuning of the therapy techniques rather than I guess explaining everything from scratch. The second benefit I've found is as an adjunct to face-to-face treatment sessions. Particularly with clients facing comorbidity issues. They might have anxiety symptoms, but they also are experiencing or they have a history of trauma or disordered eating, or quite frankly, there's a range. Comorbidity is more the rule than it is the exception. And so being able to supplement, 10 sessions with an online CBT course has been tremendous. And lastly, as a post-treatment relapse prevention option, again, I know we now have access to 20 sessions, but in many ways that hasn't really solve the problem of accessibility, because now people can just stay in the system for longer. So it's excellent, but it does have its costs as well. But having such a service available for clients who have completed their 10 or 20 sessions, rather than having to refer them to an alternate service, has also been, been quite acceptable. I tend to give my clients sort of 3 different options, which is generally the self-help options of books, or the Centre for Clinical Interventions is good, or there's the online programs like This Way Up, or Mood Gym. I don't know, there are various other ones, or referrals to alternate services, and the online CBT ones seem to be quite relatively popular. But that does take me to the barriers of there is always low uptake with the online CBT options. And part of this can be resolved through therapist guidance. If you're actually on top of, I find it's always hard for me to remember what I've told someone to do, but if I can remember what I've asked them to do, and then I can follow up with them and provide guidance about the actual stages or the modules that they've completed, then that helps with the uptake. Otherwise, if they're just not interested, then similar with any therapeutic homework, you're going to fight an uphill battle, and you have to find an alternate way to engage the young person in doing work outside of the therapy situation. Now, would you like to make an app? There are lots of apps. So many apps that it's almost hard to choose which ones to use, or which ones to use at which time. Some of my favorites are here up top, Dalio, which is good for mood monitoring. It has, easily noticed smiley faces, frowny faces, and comes out with some nice detail linking, your positive moods with certain activities. Habitica is one that I've been using to try and, particularly for my clients that enjoy more the role play game, or RPG aspect of turning their life into a bit of a game. You get fake internet points for completing tasks like drinking water, eating healthy, socializing, whatever it is that you've set your client as goals. So in terms of behavioral activation, that's been quite a nice way to encourage my clients to engage in more positive or adaptive behaviors. Reach Out Breathe has been a good app for teaching clients breathing techniques. It has a nice little monitor for your finger over the camera, monitors your heart rate, and again you get that feedback for the client about whether the breathing is actually making a difference for their heart rate. And then lastly is Smiling Mind, which is essentially mindfulness programs in a pocket, where you can, you have the convenience of directing young people towards mindfulness programs at will, really. Which I guess sort of summarizes the benefits of a lot of these apps are convenient. They're on people's phones. People are always on their phones. Whereas handing out a bit of paper and saying, complete this form, generally gets lost in the bottom of a bag. And they're generally more appealing than the printed forms that you hand out as well. However, there are the barriers. There are a lot of apps to choose from, and trying to figure out which app is going to work with which young person under which circumstances, at which point they're effective, can be a bit of a nightmare. There are some websites, I think the ANU has one that tends to rate the different apps. But again, it is tricky. So, and that leads, yes, to the barrier of what app do you recommend to which client. And essentially my answer has been, I tend to have a couple of go-to apps that I tend to pull out when I notice if there's a particular issue the young person is facing. The last area that I've been having a bit of fun with is biofeedback. So I've been using two biofeedback devices. The Muse brain sensing headband, that's a little EEG machine that's looking at brain waves while people practice mindfulness. And then the other one is the M-Wave heart rate monitor that basically, again, gives you little points and tells you when your heart rate and breathing are in coherence, and essentially in a calm state. So these have been a great way to introduce mindfulness and breathing to young people because they're getting instant feedback. I have no idea how many times I've run through a mindfulness exercise or a breathing exercise and a young person has just said, yep, that was great, but they've probably been lying to me. I don't know. But now, if I'm using these devices, then I actually have a fair idea about whether the exercise is working for them or not. And so this leads to a greater discussion with clients about the exercises and if they're going to work for them and how they need to change. However, there are, of course, barriers to this. The devices are generally expensive. Young people generally don't have the sort of money to go and buy these devices themselves. I'm also not comfortable, recommending that people go out and buy these devices because, again, the evidence base is still emerging. So it generally, keeps the devices to just occurring in session. And, again, it's debatable about if that's actually a more effective way of teaching these skills or not. So my general takeaways from this is, being careful to manage your own and your clients' high expectations of technology. And for the biofeedback devices, for example, a lot of my clients just end up trying to break the device. And they said, oh, look, I was thinking really hard and the machine said I was still mindful. Sometimes it happens. There's a bit of a lag in that information. And it's not perfect. Similar with say the InnerWorld platform. There's all these things that we want our technology to do for us, but it's really hard to meet those expectations. Then, of course, the second part, this is particularly for me, is remembering who I asked to do what. What apps did I recommend to which young person, and how am I meant to follow up on that? Again, I guess you could say, Mitch, that's just good note taking. But it is an extra step to go back to those notes, and it is extra work, which takes us to accepting the additional workload. I guess the promise of technology has always been that it'll make our workload easier, but it tends to be, at least in this stage of development, to generally, add an extra level of what we can and probably should be doing during our treatment sessions. And that is me. Oh, sorry, I can't hear you, Sarah.
There we go. Would help if I unmuted myself. Thank you so much, Mitchell. That was very informative and interesting. And as a clinician myself, I know COVID turned out to be the ultimate disruptor, and we all had to turn on a, hairpin to learn how to telehealth. So a little bit harder for the birthing of the babies, but
I imagine, yes.
maybe Rebecca could come up with some simulation for me to do that from home. But thank you so much. I do have a question. Someone asked a question about developing an app, but I imagine you're no app developer. Correct me if I'm wrong.
No, I'm not actually an app developer myself. Yes, I don't know if I can help with that.
No, that's all right. We'll leave that question. Thank you so much for your time.
No worries.
All right, final panelist this evening is Professor Kate Steinbeck. She's an endocrinologist and adolescent physician and the chair in adolescent medicine at the University of Sydney, Australia. She heads the Centre of Excellence in Adolescent Health to improve adolescent health services in the digital age. Kate has led the development of a statewide transition service in New South Wales and has researched transition for 15 years. Okay, thank you, Kate.
Thank you very much for that introduction. In about 10 minutes, I'm going to summarise adolescents, what digital technologies adolescents interact with, and show that sometimes we make assumptions that they are more technically savvy than indeed they are. I think the first thing to remember is that adolescents inhabit multiple digital worlds, and those don't always connect, and the skills to work within those worlds are often quite different. And when we're talking about healthcare, as most of the speakers have already said, it's more about access to information and looking for assistance. And that's quite different to what they might do with their other digital worlds. So something like Natalie's is an insight into one of those worlds in one particular way. So there's just a vast amount of information that they are exposed to, and we need to understand better. Now, this is my brief list of what adolescents are already starting to interact with in terms of healthcare. The ones I've got in purple are the things that we all interact with. We all get SMS reminders for appointments. We like to be able to book things online. We like to be able to interact quickly with our healthcare providers. And we know that the purple things are pretty much what they like. They're simple, they're immediate, they give them what they want. But I'm going to talk about some of the digital technologies that I think give us all headaches, and we really need to understand a little bit more about. So I'm going to actually talk about smartphone apps too and development. So that's going to be, I might be able to answer that question for Mitchell. So I'm going to run through some things that I think everyone who interacts with adolescents in healthcare really needs to be aware of. And the first thing is that our government has a digital health strategy, and it's all about safety, secure, and something else that I've forgotten now. But it's a really good strategy. It's worthwhile looking at. Doesn't really say much about adolescents. But My Health Record is one of the ways that our federal government hopes that we will be able to more easily share our medical details. And I just want to look at it from a young person's point of view, because most young people don't know that at the age of 14, their parents or guardian lose control over their record and it's transferred automatically to them, which is interesting because it's 1 year younger than when you're entitled to your own Medicare card. And at 14, that's the beginning of potential mature minor status. And so the website, if you, as an adolescent, you wanted to find any information about My Health Record, it is not easy to read and it needs badly to have some visuals, I would say. But it is important for health professionals to be aware that it's probably important to discuss this with their patients, particularly those who have chronic conditions and for whom it may be useful, or for those who have conditions that they might not wish to be shared, and to have a negotiation with who has access to My Health Record and consider the factors around confidentiality, choice over information that goes on record, and access to that record. And if you look at the Australian Association of Adolescent Health website, there's a really nice position statement which some of you might find helpful. Sorry, I'm just, that's right. Sorry. Now, some of the numbers I'm going to give you in this brief presentation are from the Access 3 study, which is a study I was involved in, looking at how young people have access to health care and health system navigation, and only New South Wales, but we deliberately sampled vulnerable groups because I think everyone has suspects that these might be the young people who have a much harder time in terms of having technology, either access to it or having the data to even use technology. But we know certainly that most young people in New South Wales have access to the internet. Most of them would be through computers or mobile phones, and only a very small number do not own a mobile phone. But we also, and I think COVID has been interesting, most of our speakers have mentioned that. And I think some of the restrictions from our point of view, where we were dealing with chronic or physical illness particularly, is that the lockdowns really magnified some of the issues that young people have with telehealth. And throughout the literature, there is a fact that adolescents often say they have a preference for face-to-face. Doesn't mean they always turn up, but they still have a preference. And neuroscience would suggest that there's a really basic science reason for that, that in middle adolescence, they do have trouble trying to read facial expressions. And I'm sure all of you have sat on 1,000 Zooms and realized how difficult it is sometimes to work out what people are thinking or saying truly. And adolescents also rate trust as really important in establishing engagement with health professionals. And it is clear that trust is probably easier to obtain with a face-to-face consultation. The thing that I think was a real problem at home was lack of confidentiality for some young people. I really found it very difficult to judge whether I was really speaking to them by themselves or whether someone was lurking behind the door. And I did have some unfortunate experiences when it was clear that somebody was lurking outside the door because mum burst in to debate what they'd actually said. A lot of adolescents found it quite intrusive and they just didn't want to be seen. They switched off their video or simply went to another room. So I think it's not always the ideal solution. Now, I often get to read grants as a reviewer, and so many of them have, let's create an app. But it's not as easy as you might think. We really have no published information on long-term engagement with adolescents with apps. We know that adolescents, like all of us, engage with apps if they're useful. And we have to understand what they find useful. There are so many health-based apps out there, and most of the apps that we might develop in a public health system just can't compete with commercial providers. And also to get user experience is quite challenging. We found the best way to do it was sort of by real-time computer interaction where the adolescent just spoke as they watched the app and made comments about its utility or not. We have developed an app called Transition Mate, which is to help young people as they transition with chronic illness from paediatric to adult care. And it was there to try and fill in that gap between leaving paediatric care and engaging with adult care. And look, we had a lot of information in the app. We had a private developer doing it because we didn't have access to in-house apps. And I think that's the key to anyone who wants to develop an app in the health system. You need to have an in-house team that will do that for you. And we're close to completion of a single arm trial, just looking at how well young people who use the app actually engaged. And the things that I can tell you, two things I can tell you, is that analytic data showed that the use fell off rapidly after 3 months. but we still don't know whether that made any difference to whether they engage better with adult healthcare. And the thing they really liked was an emotion monitor, because we know that a lot of transition difficulties sometimes stem from a lot of psychosocial aspects going on at the same time. And they really loved the emoji emotion monitor, which they could graph and see how their emotion might play a role in how they felt or what they were doing, particularly around therapy adherence. Now, we've also had some discussion about finding health information on the internet. And we know that young people frequently use it because cost is an important thing. And what they often say is that there's nothing on the websites to tell them how much it's going to cost them. They also use the internet to decide how or who to go to, and that's the very strong requirement they have, really navigating through all the healthcare services potentially. And we know that they use the information, they use the internet, and generally females will use the internet more than males for looking for health information. I'm not talking about anything else but I'm sure there are gender differences in many ways. But do they know how to do it? Do they have health literacy, which I think I've defined it there as a fairly simple definition, and the capacity to assess the validity of a website. And the work that I'm using is work led by Professor Karen Scott, who really has worked so hard to understand how adolescents navigate the internet. We know a number of things from a systematic review that her group produced. They are aware that quality varies, but they're not very sophisticated in their searching. There's no sort of systematic way of searching, and they often end up feeling overwhelmed by contradictory information. And the other thing that interests me is how they appraise the validity of a website. While they know that where that comes from, is it associated with an institution or a person who's known to have knowledge, but they're also heavily impacted by first impressions of the website. So if it's a great and interesting website and captivating, they are more likely to think that it's a good website. And I think that we need to be aware that health literacy can be taught. And in the world of digital healthcare, we need to be teaching adolescents early on about how they deal with the vast amount, and particularly as Natalie showed, the vast, uncurated, massive information that sits on social media. And if we taught them how to search well, I think they could use those skills not simply for healthcare, but for other aspects of their life when they're seeking information. Now, as part of the where do we go for good information, and as part of the digital health initiative from the federal government, there is Health Direct. Now, I don't know how many of you have actually looked at Health Direct. I pretended I was a teenager wanting to find some information on Health Direct. And so when I clicked on the contents, I had two options, either to look at life stages or the A to Z option. And I looked at life stages, and only 3 life stages seemed to be important, which I felt a bit miffed because I didn't think I was a senior. And I think teenagers would also feel a bit miffed because the kids one was really about kids. And so I decided to click on A for adolescence, and there was nothing there. And I clicked on T for teenager, and they're the topics that came up. And the first very disconcerting thing was that it was really hard to work out whether the information was actually directed at the parent or at the teen. And I think this is a major problem when we're dealing with technology. Who is your audience? It's very hard to direct it to everyone. So you have to come up with a clear plan, as if you want teenagers to engage, then they have to feel that it's interacting with them. I also clicked on Y for youth health, which sent me back to teenagers. But I did think that the young adult health information was really excellent and had topics that most adolescents would actually be seeking, particularly things about mental health, sexual and reproductive health and nutrition. So there's a lot of work, I think, to do on Health Direct to make it of more use to teens. And finally, I'm just going to mention something that I really think is going to, not absolutely new, it's been around for a while, but because of the technical developments and the reduction in costs, virtual reality has really become a real player in healthcare. And I'm just going to briefly share a few results. We did a brief VR study in the emergency department in a gateway of a couple of weeks, which we were provided between COVID freeing or absence of COVID freeing up our EDs and the 2 EDs we were working in the Westmead precinct having a major move. And we were interested with our cyber psychology partners and some funding from the ACI to look at whether VR could be used to manage distress in adolescent patients. And this is a real key issue in emergency departments. And the distress basically comes from those adolescents who are triaged quite low and non-urgent, but who become very distressed when they're not attended to straight away, because this is an emergency department. We know that VR uses immersion and distraction, and it's really been used extensively in children and adults to reduce pain, to treat anxiety, and also actually very good for dealing with phobias. But as expected, so little is done with adolescents because they're a little bit more challenging, and the funding just often isn't there to do these sort of studies. So we basically, this is the headset we used. It's an Oculus One, and it's got really 50 to 100% better on its next model just in a couple of months. They're allowed to choose Netflix, Tetris, which is a building game, and Trip, which is about an immersive environment. You can pick whether you want to be on the beach or up a mountain or in outer space. And while we found no changes in the biological markers of anxiety, and we were measuring pulse rate, blood pressure, and respiratory rate and oxygenation on standardized and validated brief questionnaires, we got very significant change in their anxiety and their comfort. And this is something we will pursue further. It was very interesting. We found it hard to engage them when they first arrived in the emergency department, but when they'd been there for about 30 minutes and realised they weren't actually going to be seen, and that we would let them go immediately to medical treatment when they were called, we got a much higher uptake. But the other thing, of course, that VR is so useful for is as an education and training tool. And I think we're probably going to start doing a lot of work on that, looking at how we can teach clinicians to engage with adolescent healthcare better. So I've given you a very brief walk through adolescence and digital technology as they use it in healthcare. The important thing is that adolescents are digital natives, unlike some of us here who are digital immigrants. And they're the first generation, if you think about it, who will use technology in healthcare for a lifetime. So they're really leading the way, and their advice and input as they grow and develop into adults and beyond will be extremely insightful. I think the digital environment is ever increasing in complexity, and we really need to also take a protective role with young people and looking at concerns about security and the use of sensitive and personal data. All of us have given a large amount of our data and information to the internet, which most people can find if they choose to search. And while adolescents are great users of technology, their knowledge and skills are really not in health spaces. And I think that's what we need to realise. I see so often they say, oh, well, this will be great for adolescents because they're tech savvy. Tech savvy only describes savviness You have to decide what areas their savviness is in, and it surely will not be in most of the things that we need in healthcare. And thank you for listening. It's always hard to be the last speaker, but I hope you found that useful.
Thank you, Kate. I think you've brought that home very well and made many, many interesting points. I've got a 14-year-old son next door who I've threatened with death if he makes any noise while gaming while I'm on this. And a bit mind-blowing that he can be an independent person for his health. I think he wouldn't know the first thing about it. But anyway, thank you so much. Very interesting. I think we've had a few people leave, not everybody. Do any of the panelists have any questions for any of the other panelists? No. Everyone's tired, everyone's hungry. Do we still have Natalie around?
Yes, I'm here.
Yes, we had look, your
Sorry.
question askers may have already left, but anyway, we had a question from Ben Bob saying, "Hi Natalie, did the pregnancy feature in any of these social media posts? Don't really understand that. Did pregnancy feature in any of these social media posts regarding diet? I only ask because currently 46% of our mums-to-be are overweight or obese. Thanks, Ben."
Okay, yes, so thanks, Ben. Featuring really in any of either the weight loss or the diet hashtags pregnancy, but I do know that there is other work going on around postpartum and what's seen postpartum for mums and information on social media around postpartum, but I don't know of anything around preconception or during pregnancy around that. I guess one of the things that's important to consider is whether they are actually engaging with social media when they're looking for that information, or whether mums-to-be might be looking at other sources for information. One of the things I guess that we were interested in is because we know that adolescents are engaging with social media and they are getting nutrition information from social media, and there is some evidence around social media use and disordered eating development, and so it was interesting to us to have a look at that and from that perspective, but I don't know about the preconception stage.
Okay, thank you. And oh, hello, we've got a rush of questions. So this is from Melanie Keep. For all panelists, in your project, what was the one thing that surprised you about digital health and young people? Or what will you take into your next project? So, Natalie, did you want to start that, and then we'll let the other panelists?
Something that surprised me. I mean, from a digital health perspective, I think it was surprising to me the kind of information that was available to adolescents. Instagram actually have some policies around marketing towards adolescents into marketing of weight loss products, but there was a significant amount of promoted products and diets that was available, and obviously they're getting around, and there has been some recent news stories around influencers getting around those policies for social media and marketing. And so the fact that there is quite a lot of marketed products that are available to adolescents through social media and the digital age is quite shocking and scary for my opinion.
Okay. Did anyone else have any pressing points in your projects, the thing that might have surprised you or not? Yes.
You want to stop? Yeah. I think what surprised me most was how willing people were to share their stories on video, in interviews, and how to help other people. You would have seen I was in one of the videos, and it's not an easy thing to do. And there's a number of people who are really willing to tell their stories. It was, for us, quite surprising, but really a really valuable response from them. Yeah.
Oh, very good. E-Lin, before you go,
Yes.
I'm going to just cut in with another question that I thought was interesting. This is from Natalie Munro. E-Lin, thank you for your presentation. Oops, it's jumped around on my screen. It was something about sexting, or how do you... Nope, it's gone. Something. She had a question about sexting and how, you know, are you going to be addressing that, or do you deal with that, or will that be?
Yeah, so we have, so part of the Planet Puberty section on keeping safe looks at safety online in the context of so relationships and social media, and also integrating that with, you know, some sort of general online safety, you know, again, pitched towards intellectual disability and autism, and also that sort of intersects within our other sort of content around private and public and the kinds of things that you can do in those spaces. So that all sort of intersects within the topic of sexting. So address sort of specifically in certain areas, and then integrating it across the board and reinforcing some of the key messages around safety and privacy.
Thank you. Did anyone else, Kate, Mitchell, Rebecca, want to comment on anything that surprised them, or shall we plot on to another question? Mitchell?
I might add something. I guess it's actually just reinforcing Kate's point of young people. Just because they're young doesn't actually mean that they're going to be engaged in technology or they actually know as much as we expect them to about technology. So I thought that was just a point that needed a bit of reinforcement.
Yeah, no, absolutely. And I did listen to Kate say that personally myself, and I thought, oh yeah, I do assume the kids are going to know what they're looking at and be able to, you know, research that, but they probably don't, obviously.
And I'd also just like to, I think this thing that surprises me is that how young people don't consider enough about confidentiality and who could see their data, their pictures, whatever. And I think it's just a very hard concept. We probably all don't think about it enough, but I think it's really wise to have those conversations.
Yeah, very much so. Kate, while I've got you sitting front and centre, I have a question about transition from paediatric care to adolescent health can be challenging, especially in regional areas. Hoping digital methods will be bridging that gap, but they can end up with complexities. And that's from Gayatri Kasaka.
Yes, look, I think it's the bind of distance, and of course with distance comes less than effective internet services too, so that I think when we assume that the internet will solve everything for us, the people who need to have everything solved don't often have the best access to that. And I certainly know there are a number of projects that are working on transition in chronic illness, transition out of acute cancer care. And I think the most important thing is to involve young people in the design of those studies and the interpretation of the data and the implementation of those studies. And as part of our Centre of Research Excellence, we have a Y Commission, which is a group of trained young people who actually assist researchers with their research and really have an amazing ability to make research useful. And so I think if we're trying to solve that big problem of remoteness, we need to hear what young people say. But I think in the end, as hopefully our digital health techniques and how we provide them become better, I think it will be extremely useful.
Okay. And Kate, perhaps one last question while you're still front and centre there. This is from Dennis. I'm going to botch his surname. Senyondwa. something like that. Sorry, Dennis. Thank you, Kate. He would like some advice on a reading source on virtual reality, if you know of one, and its use in pain management.
I do, but I don't keep. If Dennis would like to send me an email through my university address under Catherine Steinbeck, I will send some information, including a systematic review that we've published recently. So there's quite a bit out there, and I'm happy to forward that.
Okay, thank you very much. Do any other of the panelists have anything they wanted to comment on or address, or shall we say thank you very much? And Sarah Woodbury, your timekeeping is atrocious. You probably won't be invited back, but sorry about that. It's very hard to time keep with Zoom. So yeah, lesson learned. So thank you everybody for participating. Okay.
Thank you.
Thank you.
Thanks a lot, guys.
Bye.
See you.
Thank you.
Okay, thank you. You've all been fabulous.